Hello, everyone, and thank you for joining us this lunchtime at what I think might be the first of several NELA webinars. Today, we're going to discuss getting more from your NELA data. So what we're going to cover today is, this webinar is really all about data. So how to get the best from your NELA data. We'll discuss some new functions on the dashboard and things that help you as local leads get the best from the data that you're working so hard to collect. We're going to talk a little bit about mortality monitoring and EWMA charts, which is great new functionality that we've got from the data, which I think will be a real help to you. And we're going to discuss how to get access to NELA data for research and the intricacies around asking for data for research, because that's very frequently an issue that we have to discuss with people who approach us. Please do ask all the questions you like. There's no such thing as a silly question. Post them in the Q&A box and we'll address them all at the end of the webinar rather than addressing them during people's presentations. So the panel today, so I'm Dr. Carolyn Johnston. I'm a consultant anaesthetist at St George's in London, and I've been the quality improvement lead in NELA since I think about 2012, 2013. I'm joined today by Miss Sonia Lockwood. She's a consultant surgeon, a consultant colorectal surgeon in Bradford, and she's been part of the NELA project team since 2016. She's the surgical lead and also the research lead, which means that she's got exceptional knowledge of the issues around data access, which you'll be talking about later. She's also recently been appointed as the Director of Emergency Surgery at the ASGBI. We've also got Dr. Peter Martin, who's a lecturer in applied statistics at UCL. He's involved in the perioperative quality improvement project, PQIP, as well as NELA, where, as well as undertaking some of the analysis of data for each annual report, he's led on the introduction of the EWMA charts, which we'll hear a little bit more about later. But I was just going to start by talking about best practice in data. This graphic is from an article that was in the Royal College of Anaesthetists Bulletin in January of this year, where after the last annual report went out, I contacted the 4 best performing trusts in terms of mortality in the country and just talked to them really about what they thought was how they could attribute their good results, what they were doing well, and anything we felt we could learn from. I'll share a link to this article if you haven't read it already in the chat function or in the question and answer function later on. And these leads said quite a few things which were very interesting to us as a project team, and we wanted to share today and give us some hints about how we can help you with your data a bit more. The other thing I wanted to lead you on in terms of best practice for getting the most of your data is this Cochrane review of best practice in audit and feedback. So they looked, as all Cochrane reviews do, across the whole range of studies done in this area, and they came up with some conclusions about how you could manage the feedback you give after an audit to best affect improvements in outcomes. I'll also share this on the question and answer, a link to this after the presentation. They said that audit and feedback would be most effective when the health professionals aren't starting out well to start with. Of course, you've got a lot to gain there. The person responsible for the audit or feedback is a supervisor or colleague, so there's some kind of validity of peers talking to peers. They say that audit and feedback is most effective when you provide it more than once, so maybe rolling over a period of time. It's effective if you give it verbally and in writing, so using several different methods. And if you include clear targets and an action plan when you're giving your audit of performance, that tells people how they can improve. So these are the kind of things I want you to keep in the background when you're thinking about using your NELA data to best affect improvements in patient care by changing colleagues' behavior and changing your pathways. So back to my colleagues who spoke to me about their best practice, the 4 trusts with the lowest mortality rates. What did they tell us? So one group said, we hold regular quality improvement meetings at which we all present the data. And this really helps encourage colleagues to fully engage, especially when colleagues are working out of hours. Others said, we have regular meetings with all of our leads, looking at our data collection and our results. So what we found from a lot of these groups was that they paid attention to the data. It was no secret that they were doing well in terms of mortality because they'd really examined what their performance was like. This is kind of confirmed by some scientific study that's been done in this area as part of the EPOC study. So if you remember, the EPOC study looked at the introduction of quality improvement techniques to all NELA trusts nationally, just after NELA started, and they did an ethnographic, like a social study, in 6 of those units. And what they found were the teams were really positive about the benefits of reviewing data together as a team, but that they all felt that time was a really important barrier to them being able to do this well. So I thought it would be helpful to give you some time-saving dashboard help. So I hope that you're familiar with this graphic here. This is what you get when you first log in to the NELA web tool dashboard. You might be familiar with these tabs across the top, the clinical tab, where you would enter patient data, or you would review patient data if you were a NELA lead. I just want to highlight to you this new tab that's come on there, which is the poster tab. And that would take you to this screen here, which you pick your date range, you input your name of your local NELA leads, and then you can input in your own text what you think this month's priority area for or QI focus should be. And I've just put reducing time to antibiotics in the ED as my preference. And then you just press the button to download the poster, and you get something that looks like this. And so this is a PDF that you can print out in either A4 or A3. It takes your live data from your NELA web tool at the time and puts it into a series of infographics telling you what your own individual trust performance is like. So this will help you to feedback your data to colleagues frequently, because it is touch of the button stuff. It's very easy to use, and it allows you to put your job title, to put your name on it, so that others can see that, and to give them an area of focus for the next period of time. It's up to you how often you feel this would be helpful to your trust, but certainly in my trust, we've been sharing our data 3 monthly, just to give everyone an idea of how they're doing. And this has gone down really well in the operating theatres. You can imagine it put up in the coffee room in the operating theatres, or the anaesthetic department, or the surgeon's coffee room. So another group said to us that they felt that joint M&M meetings were particularly helpful to discuss their data. And so they meet to discuss all NELA cases, and they discuss their data, and it's a really helpful way to bring teams together. And I think particularly M&M meetings, we feel that people who engage in multidisciplinary meetings, surgeons, anaesthetists, ED, radiology, intensive care, and AHPs where they've been working in your pathway has been really helpful. So I just want to highlight something that's particularly helpful for M&M meetings, and also for reporting some of your radiology standards and reporting some outcomes for individuals, for example, for appraisals. So if you go to the reports tab on the dashboard, and scroll down to the bottom, you get to a thing that is called the Excellence and Exception Report. And if you click on that, it downloads a file that looks something like this. It's an Excel spreadsheet, and it has a macro in it. So sometimes that means that trusts net nannies go a little bit crazy about downloading it, but it's just a simple Excel spreadsheet with some macros embedded into that. And what you can do is you can download your NELA data from the web tool and plug it into that Excel spreadsheet, and it will give you a series of reports which you can use to analyze your own performance and to share with others. Let me give you an example. The excellence reports show you that who has met all key standards of care. So we feel that learning from excellence is just as important as learning from people who don't meet the standards. And this shows you, I've grayed out because this is real patient data, that you might that you get the basic demographics of the patient, and then you get performance according to the key standards of care, CT scan performed, risk of death documented, and so on. And then you can very easily see on the highlight where patients do or do not meet the key standards of care. This exception report for M&M meetings is extremely helpful. I've given you a little bit of a kind of zoomed up view of that, and as you can see, there are some filter tabs on a number of different I'm just going to draw on there. You've got some filter tabs here like this, so you could click on that and just filter out all the patients who do have discrepancies, for example, on their CT, and that makes a fantastic database that you can send to your radiology lead or your radiology department to see if they can give you any help with that, and whether they want to do any analysis of those cases themselves. The other thing that I'd like to highlight there is that this part of the report here shows how many patients are eligible for best practice tariff and who meet the best practice tariff. So if you're currently working towards meeting that best practice tariff as part of some cost improvements or together with your managers, this is a very helpful screen for many different purposes. And these are all just Excel files that you can, save and share as you need to. So moving on quickly for a few more dashboard functions. I'm just going to take these things off here. So the dashboard has been changed to include some new types of charts. They're extremely easy to use. They're very easy to download as images just by clicking on the three little arrows or the three little lines on the top right. And these new reports, you can filter out patients according to indication for surgery, according to procedures. It'll also give you a breakdown of age, ASA, urgency, and risk. You can toggle on and off a number of different lines, looking at your own hospital's data against national data, against your AHSN or your regional data, and also against hospitals of similar size. So people would like to compare, for example, large teaching hospitals with other large teaching hospitals, or district generals with other district generals, and you can do that to some extent with this function. We also have the ability to see patient level function too. So we've got patient level data for the time it takes someone to get to the operating theatre and the length of stay for patients. So this is what that chart looks like with the lines looking at the average data, but the little purple dots as individuals. So here you can see on this data, we've got one or two patients that seem to have waited quite a long time for the operating theatre. If I hover over those, then that gives me the patient ID and I can look at that in a little bit more detail. And again, you can toggle on and off local, regional, national data there, and you can download that as an image to share on other reports. And then lastly, for me, the other bit of new functionality we have is around sepsis. So we know this is a standard of care that people find it very difficult to report against and very difficult to meet. So there is a sepsis tab on the dashboard now where you can look at that. That tab gives you whether the patients had antibiotics within an hour or not, the time it took them to get to theatre, so by that is an analogy of source control for a lot of patients, and whether they've had their lactate measurements. So these are all elements of the sepsis 6. You also have there a table of patients that don't meet those standards of care, so you can link back to that patient's NELA record and look into them in a little bit more detail why they don't meet that standard of care. So that's just a quick run through of the functionality of the NELA dashboard. I'll happily take any questions on that or data feedback at the end of the presentation, but I think I'm handing over now to Sonia, who's going to talk about data access. Is that right, Sonia?
I'm going to go a little bit through the current national picture, what's been happening with NELA data, both in the last annual report, which was published in November of last year. I'm going to do a quick snapshot of the COVID report. I don't want to step on Sarah Hare's toes. She's got a fab webinar planned for a couple of weeks' time to go through that in more detail. But I also want to just have a bit of a talk really with you about where we go from here and how we use NELA data moving forward. So I think it's fair to say that NELA is now more than just an audit. It is by far the world's largest database of emergency laparotomy patients. We have in excess of 140,000 patients now registered in the NELA database, which means it's a powerful and important resource for us all to access. From the outset of NELA, we've had somewhere between 173 and 178 hospitals and institutions contributing, and this is effectively your data. You've put it in, and therefore it's your data to use, and I want to try and encourage you to do so. We've been using it as part of quality assurance. You'll know about the annual reports, the interim COVID reports, and more recently, in the last 2 or 3 years, we've been producing quarterly reports, which hopefully gives individual hospitals a slightly more up-to-date and real-time image of where you are, but our downloading of the data from the national data set through NHS Digital means that we're always just a fraction behind. It's important, as Carolyn's just pointed out, that we're now using this data for quality improvement and hopefully using it more for research purposes. Quick summary of year 6. I'm sure all of you have seen it. Hopefully the new format of the report has made it slightly easier for you to just get a snapshot picture of what's happening. But overall, you should be very proud of yourselves for what we've managed to achieve as a country, bringing the national mortality rate down significantly from just short of 12% in year 1 to 9% last year. Length of stay and obviously associated comorbidities have improved. We're risk assessing nearly all our patients. And for those that are not sure why we ask you to risk assess, it's because even if we don't, for patients who do not receive a risk assessment, a documented risk assessment, we know that they behave like the highest risk patients. And therefore the importance of risk assessment means that they're more likely to receive the processes of care afforded to them and their outcomes generally better. I think, having looked at the participant list, I'm talking mainly to anaesthetists, but surgeons unfortunately have always outperformed anaesthetists in being present, particularly out of hours, but you guys are finally catching up, which is good news, both for our patients and for trainees. Patients are getting admitted to critical care as they should do, and the involvement of the Royal College of Radiologists means that we're getting CT scans on patients preoperatively reported, and therefore our negative laparotomy rate has actually been seen to reduce. Finally, patients are getting to theatre. I think there's a lot of work to do with sepsis, as Carolyn's just pointed out. We still don't appear to be reaching time to antibiotics as we should do, whether that's data capture, whether that's actually the fact that we're not quite getting to the patients as we should do with involvement of our emergency department colleagues. We'll find out in due course. And finally, we've recognised the importance of the frail patient, a lot of work done from Susan Mook's team up in Scotland, and hopefully we'll put some work forward over the next couple of years to improve the care of the geriatric and frailty cohorts. So, snapshot literally of COVID, it has had an impact. We've seen fewer laparotomies performed in the same time this last 2020 as we've seen in 2019. Just short of 1,000 patients had a perioperative diagnosis of COVID, and for those that were COVID positive, their mortality and length of stay significantly longer. But what you want to know is how to access your NELA data, and I'd encourage you to do so, both either yourselves and or trainees, because this is a huge resource. With over 140,000 patients entered, it doesn't matter what subset of patient you're looking at, the volume of patients is such that the methodology and any findings that you're able to glean from it are going to be reasonably robust. And you'll see from the peer-reviewed papers that have been published from NELA, we've got some excellent journal articles because the data is so good. You can access your NELA data effectively in 3 ways. You can access your local data, and Carolyn's just shown you really how to go about that in quite a structured manner. There is a regional or a multi-centre approach to it, and then obviously there's access to the national data set. So local data can be used for quality assurance, also for quality improvement, and the first point of contact is the local NELA lead. Every hospital has a local NELA lead, and then there should be a sub-lead for anaesthetic or surgical division, whoever's not leading on the first. It's important that you follow all your local R&D principles, register your audit with local audit department, but it's using the NELA dashboard, as Carolyn's just been through, and the output reports is by far the easiest way to go about it. Get to your NELA data set, you go to audit tools, click on patient entry. Carolyn's been through it in slightly better detail than I'm going to do, but reports and support are on this page, and you'll see that this is a slightly old snapshot because we've got the poster tab just missing from there. If you're going to access your data on a regional basis, then again, you can, sorry, that's national, regional databases, you need to go to search for the NELA leads in local hospitals. You don't need any additional permissions and you don't need any additional research information to come through. Each hospital, you'll find their NELA leads. There's a search function under audit tools. Contact it, use the local collaborative trainee groups are quite helpful. I was on a meeting last week with the North East AHSN. They've got their act together. They're really well supported. Individual hospitals in the North East of England are working well together. And I think the AHSN leads with the ELC project that was running up until quite recently have been a good point of contact of collaborating regional data together. But it's national data that tends to be where people want to reach the whole of the data set that runs into slightly more difficulties. You need a little bit more patience and a little bit more enthusiasm, shall we say, to go ahead. But there's plenty of data on the NELA website. If you go to the research tab as shown, there's a NELA data access requests information section and also detailing current collaborations and what projects are ongoing. How do you go about it? So through the website, there's a NELA data access request form. That's a 10, 12-page documented form which asks you to detail the project for us. NELA has the process of looking at the clinical validity of any requests that you're asking for. Is your project valid? Is it going to add something new to the data? And we need to check that somebody else isn't already doing that work. And if we have got a project or a team that's already ongoing with a similar idea to yours, then we are able to forward you on so that you can avoid duplication. HQIP are the people who actually own the data and will give you ultimate approval for it. And there are some significant legal loopholes you have to go through, and I'll cover that in just a little bit more detail shortly. But the data access form, for those of you on the webinar today that have sent things through, I get many of these that come through for approval, and you have to be as specific as possible. You literally need to list the rationale and the reasons for every data point that you're requesting and why you need it. Once we've got the access form through, we usually send it back. There's a couple of queries often, or little bits of advice and information that we send back to you, hoping to make that form more accessible. It goes through the NELA project team for us to approve it and then sent on to HQIP. HQIP will, for large organisations, probably charge you a cost of putting through the data access request itself and also for releasing data. For smaller research groups, as in an individual team at a hospital rather than a formal grant associated group, can often waiver this charge. But it's just to be aware that there sometimes comes a financial burden to it. NELA has to ensure that you're going to use this data responsibly, that you've got an appropriate server to bring the NELA data onto for confidentiality and IG governance purposes, but also that you've got a way of disposing of the data once you've finished with it. We ask that you give a regular update to the NELA project team and let us know where you are along the lines of the project. And also you're required to acknowledge NELA in any academic outputs that have come out of your work. So the pitfalls, the first thing to be aware of, this is audit data, it's not research data. And I think it's one of the things that I came across quite early on of joining the NELA project team in the first year of writing the report. It's nice to try and put an association with findings and one thing leads to another. That's not the case. Audit data literally gives you an indication of that data entry. It's not research data, and therefore trying to assume one thing as a cause and effect is often very difficult, and you should try and avoid it. We've had multiple teams come through trying to duplicate previous projects that have already been either completed or are ongoing, and that's why it's worth contacting the research lead at NELA just to let you know what's happened. There is huge problems with the legal basis for data access. We have a legal basis for being able to collect NELA data, and that legal basis extends to being able to release it to you. So quite often people who have sent through a data access request, you'll be surprised that the main issue is that they think they're getting or requesting anonymized data, and actually many of the data sets are identifiable, and therefore the data access requests don't go forward. What we are able to do for many of the identifiable things is that the NELA project team and our analysts can actually change either, so date of admission, date of death, things that are identifiable, we can change them into time scales rather than individual dates, which should hopefully help. But again, that sometimes comes with a cost implication for the analyst's time. I think the main issue is that people underestimate the time scale it takes to access NELA data. And I think from start to finish, you're looking at a good 8 to 12 months from putting your original access request in to coming through. Each of the members of the NELA project team are full-time clinicians, and therefore when you put a request in, it comes through to me. That's part of my full-time job, is it's not part of my full-time job, sorry, to assess NELA research requests. And therefore, by the time it comes to us, it goes through the project team, which meets monthly. It then goes to HQIP. HQIP have a research project team that meet again monthly. It can take some time before you actually get the data that you've requested. And again, just be aware that there are cost implications, sometimes from the Royal College of Anaesthetists and the NELA team, as well as HQIP. But it is worthwhile. This slide's probably slightly out of date now. We've had 9 peer-reviewed publications that have been in high impact factor journals: British Journal of Surgery, British Journal of Anaesthesia, Annals of Surgery, and they've covered both projects that people have requested data for, as well as projects from our NELA clinical research fellows. We've currently got 13 projects that are ongoing using the whole of the NELA data set. We've had presentations using NELA data across the world in over 65 different international conferences and meetings. And obviously NELA gets cited in large high impact peer-reviewed papers and other studies. There's some opportunities to ask questions later, but I'd encourage anyone, if you are interested in using NELA data, to get in touch with the NELA project team, and hopefully we'll be able to facilitate that for you. Thank you.
Thanks, Sonia. Hello, everyone. I'm Peter Martin. I'll do the third presentation. Let me just share my screen. So as Sonia said, there's opportunity to ask questions in the Q&A chat, and we'll then take all the questions at the end. So I'm here to talk about EWMA charts, EWMA. So that stands for exponentially weighted moving average charts, a bit of a complicated name, but it's really about the ability to monitor mortality in real time using the NELA data as you put data in. So as many of you will have seen, as part of the yearly NELA report, we publish a plot like this. It's called a funnel plot, which monitors the mortality rate in the hospitals that take part in NELA. So in this plot here, each dot represents one of our approximately 180 hospitals, and we're plotting their adjusted mortality rate using the NELA risk adjustment model, which adjusts for case mix using things like patient age, the ASA grade, and physiological measurements such as blood creatinine and so forth. And so hospitals are compared to the national average mortality rate over the last 3 years, this has been approximately stable at about 9.7%. And that's plotted in this plot as the red line here. And so some variation around this average is expected because you wouldn't expect every hospital to be exactly on the average. There'll be some statistical random chance variation around that. So a little bit of difference from the national average is not something necessarily to be concerned about or be happy about, depending on where the difference is. But to aid us in evaluating what might be an unusually high or unusually low mortality rate in a hospital, statistical methods are used to draw these control limits. So these are these dotted and dashed lines. And as you might know, there's a formal outlier policy that NELA is required to implement by its funder, HQIP, to notify hospitals that exceed these control limits of the fact that they seem to have an unusually high mortality rate, that then hospitals get the opportunity to respond to that and potentially even to amend aspects of the data if one of the problems was in the data not being correct, for example. So the funnel plot is very established statistical methods and it has its uses, but it has some disadvantages because it comes quite late. So the funnel plot is usually published in the autumn after the yearly data collection ends. So, and that means it's published almost a year after the most recent patient covered in the report has had the operation, and almost 2 years after the first patient covered in the report has had the operation. So if hospitals are identified as an outlier, for example, then the data they need to review are between about 1 and 2 years old. And that makes it more difficult to review these data. You know, you don't remember the patients anymore. You don't remember what happened necessarily in that year. But also it means that if there actually is a problem that you'd want to address, and now a year has gone by before you had a chance to actually address it. So to deal with that issue, we've introduced these charts here, which allow you to monitor the rate of deaths in your hospital in real time or as close to real time as possible, meaning as you enter data and log the cases, this plot is updated automatically on the website. I'll show you later where to find it, but I thought I'd spend a little bit of time explaining how this plot works. So this is called an exponentially weighted moving average chart we call it EWMA, so EWMA. It's a rather complicated name because there are some reasonably complex mathematics behind it, but the conceptual understanding I hope is not very complicated. So this chart is drawn for a single hospital. So in the NELA web tool, you see it for your hospital. And again, it uses the national average mortality of recent years as a comparison. That's this gray line here. It's about 9.7%. And it monitors your hospital's mortality rate, that is shown here as the red line, where each time you enter a new patient, this red line is updated, and there's a mathematical procedure in place to sort of update this plot with each patient to arrive at a sort of current estimate of your mortality rate. And this is the unadjusted mortality rate, so it doesn't, the red line in itself is not risk adjusted. So for example, if on the 28th of November 2019, which is the last date shown here, the red line is at about 11%. That's the current best estimate using the information from the chart of what might be your current mortality rate in the hospital. So each time a patient is recorded to have died in hospital, their estimate goes up, and each time you enter a patient who has survived their stay in hospital, the line goes down a bit. So the line is continuously updated as you enter patients. Now, for comparison, another line, the blue line here, is drawn, which tracks the average risk of the patients using the data you've put in. So using the NELA risk adjustment model, so using the patient age, the ASA grade, and so forth. And it gives you an indication of the average risk of the patients in your case mix at any point in time. So this also is updated with every new patient you enter. And so comparison of the observed mortality, the red line, and the predicted mortality, which is the average risk, gives an indication of whether your mortality is approximately the same as predicted, or higher than predicted, or lower. So in this example, the observed mortality is a little bit higher than predicted, but because some variation around the prediction is always expected, so we draw these statistically defined control limits, similar to the funnel plot, which are here indicated by this blue cloud. So an interpretation is that as long as the observed mortality, so the red line, is within the blue cloud, it's sort of within statistically expected variation of the prediction. So the advantages of this EWMA slide is really that, so I should go to the next slide actually, is that it monitors the mortality in real time. So you can use it in local teams to monitor what's happening in your hospital right now, or as up to date as your data are. And so it gives you a chance to detect potential problems sooner, and what these problems might be, I'll talk a little bit about soon. The EWMA charts are not part of the formal outlier policy, meaning the NELA team don't monitor them systematically. We don't notify you if we see something unusual in a chart. So they're a tool really for local teams to use in the way that they want. So either for QI purposes, so it might allow you to, for example, identify a period where there were several deaths in a certain time period and to check, well, what has been going on there? Is there something to worry about? But it could also be an indication for you to think about, all right, our mortality rate seems to be quite high from this chart. Does that mean we are in the next annual report, we might be an outlier? Should we do a bit of a data check now to see whether we can identify why this apparently unusual result seems to be the case? So a formal way to use this chart as a warning system is to use these control limits I just talked about. So the rule of thumb is if the red line exceeds the blue cloud, so is above the blue cloud, and in this example here, that happens at the point that is marked here by the black circle, there would be like a warning sign to tell you that we should probably do an investigation of what's going on. So it doesn't automatically mean that something bad is going on for your patients, but it does indicate that, well, the mortality rate as measured by this chart is currently higher than would be statistically expected if your mortality rate is near the national average, given the risk adjustment. So an event like this, when the observed mortality is higher than exceeds the upper control limit, so is higher than the blue cloud, should be a reason to investigate. And I'll talk very briefly about what this investigation might look like. So the first thing to say is that such a reason to investigate doesn't mean automatically that there's need for panic, because there are many reasons why a control limit might be exceeded that have nothing to do with that the hospital is putting patients at risk. So the most common reason for unusual events is actually issues with the data. So, for example, you might have entered many patients who you might have locked cases relating to patients who have died, and might have not locked cases of patients who have survived, in which case the information the EWMA chart gets is all about patients who have died, but not about the survivors. And that would lead to an increased estimate of the mortality rate. So the solution to that would be to log all the cases as soon as you have the information complete. Another problem with data might be, have you entered information correctly? So, for example, have you actually correctly entered the ASA grades of the patients? If you enter a low ASA grade when really a high ASA grade would be appropriate, then the risk adjustment model won't correctly adjust for those patients' ASA grades, and that might lead to your mortality rate being or rather your predicted mortality to be quite low, and therefore your observed mortality to seem high relative to the prediction, even if in reality, because you actually in reality had higher risk patients than you've told the chart, as it were, you'd have an artificial warning trigger, even if in reality your mortality is about what was expected. So case mix could be another set of reasons why your mortality might seem higher than expected. So we do adjust for case mix via the NELA risk adjustment model, but of course things might happen that our risk model cannot adjust for. And I was always struggling to find an example of such an event until last year. And of course, now I've got for the rest of my life a very clear example in that our risk adjustment model, of course, does not account for the COVID-19 epidemic. So if in this current year your mortality is higher than expected, the COVID-19 epidemic might be one of the reasons for that. And only once these things have been ruled out, it might be worth investigating that whether actually things are going on clinically that could cause some people to unnecessarily die, such as things with hospital resources. Do we have enough staff, clinical processes, or individual clinicians? So where to find these charts, the EWMA charts? Well, if you log into your NELA web tool, then under reports, there is a tab here labeled EWMA. And if you click on that, you would get a chart like this. So this is a simulated data, simulated chart. Doesn't relate to any particular hospital, but you get here with slightly different colors, the same display I showed you earlier. And you can also, if you hover your mouse over particular data points, such as indicated by this yellow arrow here, you can actually see the numbers and the exact dates underlying the chart. We have also published quite detailed documentation that goes into far more detail than I have been able to do in this short presentation regarding what a EWMA chart is and how to read it, and advice on what if you see an unusual result, such as a control limit being exceeded. So there are two documents that we've published on the NELA website. If you go to this link provided here, you'll get to the page I'm showing here, and clicking on one of these two links will lead you to this detailed documentation. The EWMA charts have been live since last autumn. We hope they'll be useful to you in various ways, and we'll be very happy to receive feedback also how you're using them and whether there are things we could improve in the display or the documentation of these charts. So with that, I close the presentation, and thanks very much for listening.
Thank you very much, Peter, and thank you, Sonia, as well. very interesting. I've just been and looked at our own EWMA charts as well. It's so interesting to see how it varies across time. I'd recommend you all to have a look at them. Very informative. I'm just going to read through some of the questions here, and then I'll maybe ask some of the other panelists if they want to answer some of those. So the first question we got is around the use of HES data for our estimated cases. I recently found out the estimated cases for all hospitals for last year has been based on HES data from 2019 pre-COVID. So we're all estimated to do a lot more cases than we actually do as the numbers reduced during COVID. Time for Neela to look at getting actual numbers for each data analyst from data analysts for each hospital rather than estimated cases based on historic workloads. Sonia, do you want to answer that question?
Yeah, so we actually link with HES data to check that each hospital's case ascertainment is correct. So you'll know that in order to meet the green standard for case ascertainment, you have to enter 85% of your emergency laparotomies onto Neela. Ideally, we'd love everybody to put 100% of their emergency laparotomies onto the NELA data set, but we have to be realistic and that doesn't happen. So HES is used to check off your self-reported emergency laparotomy caseload versus what actually happened according to hospital episode statistics data that gets put through central NHS England and similarly through the Welsh system. We recognise that obviously the predicted values from HES is going to be subtly different from the emergency laparotomies that were performed during COVID, but without giving you too much detail away, those emergency laparotomy numbers have come straight back up again. There was a dip and they've come back up. I'm sure that when we start going through the latest download ready for year 7 report, we'll take into account those factors. But we need HES to make sure that you're entering the correct cases, that you're documenting, and therefore we can go back through the HES codes and make sure that patients that have been included are actually meeting the inclusion criteria, but also that your case ascertainment is correct. So we do need that as a second point of contact to ensure data accuracy.
Yes, thank you, Sonia. And I would say in answer to that question that the estimated cases are just helpful for you to know where you should be. So if you know your numbers are different because your own analysts are telling you so, then that's great. I think our ability to get in real-time data from each trust, from an analyst in each trust, and then report that back to you is pretty limited, and we only have access to HES once a year when we download the data. So thank you for the question. Thank you, Sonia, for the answer. The next question we've got is around the BPT, the best practice tariff. I recently found out our NELA BPT has been suspended since March 2020, which is a London NHS trust. No date set for return. This came from NHS England apparently. Is it being seen more widely, and any more info about this? Well, I'll do my best with BPT. It is a bit of a labyrinth. We regularly have these discussions in the project team too about the best practice tariff. So the tariff is set nationally, but it's administered locally. So it's a decision for your local commissioners whether they want to apply the tariff or whether they want to go on the alternative, which is called a block contract. Now, during the COVID pandemic, most trusts went on to a block contract because that enabled people to be sure of their income and to have to the ability to avoid some of the reporting around individual cases, which means that things were simpler during the COVID pandemic. So this is very much a local decision for your clinical commissioning groups. We've got indication from NHS England that the best practice tariff is going to continue for at least another year, which is good news. And we've got some indications from NHS England that the future tariff is likely to be a mix between a block tariff, so guaranteed some money for doing the activity, and an element for quality on top of that. So the BPT will be with us for another year, but that's dependent on your own local commissioning group, but there's likely to be a quality element in payments in future years after that. I hope I've made that clear. Best practice tariffs not really clear with anyone, but I hope I've helped with that. Wendy asks about the poster tab. She says, I can't see the poster tab. Where is it? On my homepage, I only have home, clinical reports, news, user profile, and support. So I think, and I've just been checking that with the project team, we think that the poster tab is visible if you are a local NELA lead who has a different level of access to the data than most of us who are just entering data. If you're a local NELA lead and you can't see it, Wendy, do email the help desk, which I think might be info@nela.org.uk. And if it's not, someone's about to correct me. And they'll be able to help you with that. If you should have access to it and you don't at the moment, it's probably because you're not on our list as being a NELA lead. I'm going to ask the fourth question first because the third one is back for me and I want to break it up a bit. What morbidity, mortality statistics or scoring system should we discuss with patients as informed consent? Sonia, do you want to take that question?
Yeah, I would use the NELA risk score. So a lot of work has gone into looking at the NELA risk score as a validated scoring system to look at mortality. It doesn't actually give you much morbidity information, which Possum used to do, but we know that Possum grossly overestimates both mortality and morbidity once the risk of death goes over 20%. So NELA risk scoring itself has been validated. So that's a scoring system that you should use.
Thank you for that, Sonia. And I've got another question here from Bala. ELC was a good tool for collaboration and team working regionally. Is this going to restart again now that the COVID numbers are coming down? We have not had any ELC meeting now in East of England for a year, roughly. I agree with you, Bala. The ELC has been fantastic at letting people work in regional collaboratives, and we've seen a lot of really positive changes come from the ELC. The original funding had stopped for that phase of the collaborative, and the Emergency Laparotomy Collaborative team are just waiting for NHS England and the academic health science networks to agree on what the funding model for them might be over the next year. And if I had a crystal ball, which I don't, there will be some effort between us and the ELC group to support some of those activities as best we can. And some regions that where I've had particularly good engagement with the projects will probably continue to run something through their patient safety collaboratives, but that will be agreed more locally with your AHSM, you say East of England. So some of the functions we will be able to support, and some of them will be in the sustainability phase of that program through the patient safety collaboratives. Right, let me scroll down this list. I'll definitely read out the start of Patrick's because he's very complimentary. Hi, thanks for the excellent presentations, and he wanted to ask a few questions. Is there anywhere where the definitions of how an outcome is obtained, e.g. sepsis, is this based on just white cell and HR data, criteria, as in temperature, respiratory rate, and so on, is not collected? Yes, it's there is a little kind of web link at the top of the sepsis dashboard that tells you how that's been obtained. So there is a question on the dashboard that asks you whether you think the patient has sepsis either on admission or at time of decision to operate. But we also look at the conditions that are indicative of sepsis. Have I got that right, Sonia?
Yeah, so we've actually looked at the indications for surgery and broken them down roughly into obstruction, perforation, ischemia, malignancy. So it depends on the indication and surgical findings. That's how we get the definitions of sepsis.
Yeah. And then Patrick also asks, risk-adjusted data, is there any way we can calculate this locally? Peter, do you want to answer that one?
Well, so in the so when you put in the data, a NELA preoperative risk score is automatically calculated. So that is that is the risk for that patient. That is in fact the information that goes into the calculation for the funnel plot and the EWMA charts. I'm not sure whether that is what you meant. If you meant to actually calculate the risk yourself from your data, not using the tool, the information on how to do that is published, and I can I will look for the link and post it here if I find it in time. But it is on the NELA website, a detailed documentation with an equation for how it's actually done.
Yes, to calculate observed over expected against expected mortality, but that is what the EWMA chart is giving you in real time, which is why I think it's been so helpful. And then if I could go back to Sonia with this one, similarly, 30-day mortality that Neela gets from the ONS, we can only look at in-hospital mortality from our downloadable data. Presumably, oh, maybe this is for Peter. Read it before you say that, Carolyn. Presumably the EWMA data for mortality is inpatient mortality only?
Yes, that's correct, because it's in real time. So it only uses inpatient mortality. So in the funnel plot, because we're then able to, because it's published months after the operations, we're able to also get death registration data from the ONS. And so we'll take, in the funnel plot, we'll take additionally into account the relatively small number of patients who die within 30 days, but don't do so in hospital, but rather die between leaving hospital and a month after the operation. So that's a slight difference in how we measure mortality for these two cases, but it's in most patients' cases the information that goes into the EWMA chart will actually be correct. Okay,
thank you. Next one for Sonia. Are you in any way able to compare the data with the denominator? All eligible patients for laparotomy. How do we know that the hospitals with lower mortality aren't excluding higher risk patients for surgery? 2% mortality for an emergency laparotomy is the same as for an elective colorectal cancer resection.
So we don't have the denominator. There's a lot of work going on. Susan Moo's group is looking at defining the denominator. So ELF2 study has started about 4 or 5 weeks ago, which specifically is going to look at the no lap groups. What we can look at, and that goes back to the question about HES data, is if people are not operating, then their actual case ascertainment will go down. So that's why we use HES data, to make sure that there's no gaming and people are either using the risk assessment tool and suddenly stopping doing laparotomies on high-risk patients. I'm not aware of a unit that's got a 2% mortality rate. I think the best is around 5% nationally. So, but that's the whole purpose of comparing with HES, is to make sure that people are not operating, which is why they have artificially high or low mortality rates.
Okay, thank you. Looking at BPT quarterly report, it looks like the case ascertainment's quite poor. Is there any way we can improve it? So I'd say two things. I'd say, as discussed earlier, that's an estimated ascertainment, so it might be lower at this time, and that might be reasonable. But the other thing to do is to look at some of the other best practice reports. So that report that I shared on the chat from the best practice sites, they all talk about how they've captured data and how they've worked with local teams to capture data. And also, if you look at the previous NELA reports, we do talk quite a lot about the best way to get your case ascertainment up, and a few little case vignettes from places who've been good at getting their case data up. So I think those examples from other units is the best place to go on that. I'm going to rush through a few of these because time is beyond us, but we've got loads of questions. Is NELA considering publishing mortality data specifically per consultant, similar to other specialties, such mortality per colorectal consultant, for example?
No, is the answer. And that's because I think if you look at the patient pathway and the patient journey, there are multiple points throughout the patient journey, from pre-hospital, admission into hospital, to the point of surgery, and then the aftercare. So it's an endeavour that involves multiple specialities, multiple levels of care, from nursing right the way through to consultant level care, and therefore individual consultant data is inappropriate in this instance.
Yes. I have a question from Mark, someone we all love to see, a perioperative geriatrician. We have access to the database, but not a site lead, so unsure of the permission differences. What's the best way to get age-specific older patient data and outcomes for NELA cohorts? Is there a separate report function, or is the best way to use the filter function on the Excel sheets? So what I would say at the moment, Mark, is probably the best way for you is to use the filter as you discussed, either on the excellence and exception report, which you can do, or by looking at the raw data itself, which you can download, which has a lot more detail, but is possibly a little bit harder to understand. We are going to be making changes to the web tool and to the dashboard over the coming, I'm going to say period of time, so I don't give our project manager a heart attack. And we'll look to include more reporting specifically relevant to care of the elderly on that. So that's a good call, and I think it's watch this space. Then we have another question about good case selection. I think that Sonia's answered that previously. And then something, how to improve frailty scoring and geriatricians' involvement in NELA. I would ask that person to go to have a look at the annual report from last year, which talked a lot about frailty and care of the elderly, and have a look at some of those best practice examples that were in the recent bulletin, because they talk about that as well. I can see Peter's typing an answer to Marianne, so that's good. Has anyone been able to access BPT to invest in emergency laparotomy services at their trust? That's a complicated one to answer. I think that's probably for people to discuss as a cohort rather than for us to answer in the webinar. Maybe there'll be examples from your local laparotomy collaborative that could help you with that, Sanjoy. Sarika says, in my trust, a lot of people use Possum as it's a simpler form. How can we encourage people to use NELA scoring instead of Possum? Sonia, do you want to answer that one?
So Possum is no longer, so if you're using Possum, firstly, then your patients have not been appropriately risk assessed. Like I said, especially if you're calculating a risk above 20%, it's inaccurate. And the difficulty will be that we don't use Possum in any of our analysis, either on the EWMA charts, your quarterly reports, or in the annual reports. You can access the NELA risk tool on the website, and the app for a downloadable NELA risk assessment tool is coming. Again, I'll say shortly, as not to cause the project manager undue concern, but yeah, once we've got the app up and running, there was an app, the app got withdrew, and then we're going to reissue the app, which makes it easier. So please spread the word that Possum is not accurate in this patient group and should not be used.
Yeah, thank you. Dimitrios asked, do we have any data about mortality for NELA patients having procedures out of hours, nights or weekends compared to normal working hours? I think that's another one for you, Sonia.
We do. That's all in the annual report. So, and there's some lovely colourful drawings in the annual report if you have a little look halfway through. And it's relatively reassuring that actually out of hours patients don't do any significantly less well in hours, which is a huge improvement from year one. So go back to the year 6 annual report and you'll find that detailed in there.
Okay, thank you very much. And then I think I have one last question. If a hospital doesn't enter NELA data or not enough data, how else can a trust board monitor their emergency laparotomy pathway? Sonia, with difficulty?
Yeah, with difficulty. So hospitals that enter less than 10 cases into the NELA data set are actually excluded. And there were a series of hospitals, so one of the cardiac units in the Midlands had a few presumably ischemic bowel after cardiac surgery, but not enough to be included into the NELA data set. But yeah, it's a mandatory national report that you're expected to enter. So if you're not entering sufficient cases, then you'd be shown up as one of the hospitals of concern and get contacted by HQIP and the Department of Health. So yeah, that shouldn't be the case. Please enter data.
Thank you very much. And then I have a last question about a plan to relaunch the app, which I think you've covered already, haven't you, Sonia? The other thing I would say about that is the web page is actually mobile enabled. So if you look at the web page itself on your mobile phone, it's possible to do it through a normal mobile phone without a specific app as well. So I think we've come to the end of the questions. I just want to say thank you to the panelists, Sonia and Peter, and also big thank you to Lucy from the college, who's done a lot of work in helping us through the IT and the events team that have advertised today's session, and Christine, who's our project manager, who is, as always, guiding us along the way. So yes, I save that date for that COVID webinar in April on our COVID specific report. But thank you very much for your time today, everyone, and enjoy the rest of your afternoons.